Hello everyone, Kent Bressler here. I want to welcome you to Kent's Kidney Stories. During our time together over these podcasts, I'd like to discuss kidney disease. I'd like to tell you about my journey as a transplant patient, but also talk about dialysis, kidney donation, and just about anything else that might be of interest. Kent's Kidney Stories, podcast endorsed and sponsored by kidneysolutions.org.
Hello, everybody. I'm glad to be back. I'm going to do some podcasting today. This is Kent Bressler from Kerrville, Texas. And I always start the new year out, but I always start all of these out with a prayer, and I hope you can kind of bow your heads and fold your hands or whatever you feel comfortable to listen to the Lord's word. Heavenly Father, help us to be strong and courageous according to your word, being careful to obey your word. Help us not to turn away from you. We want to act with your strength and wisdom wherever we go. Grant us the strength that comes from knowing your word. May it be the source of wisdom and success in our lives each day. Encouraged by your strength, we will not be afraid or discouraged. Thank you for being with us whenever and wherever we go. Amen. So the holidays have been, they've been great here at Kidney Solutions. We've had several transplants, some living and some deceased donor, but I can add that most people, everybody is really doing well. And that's encouraging.
Mm-hmm. Yes.
Finding living donors has been difficult, and we're searching all the time, but we have a saying here at Kidney Solutions: we won't worry because we don't find them, God sends them. If you have been listening and God is talking, he talks to you all the time. And if you're listening, you'll hear his asks for you. If you would like to ask, or if you want to donate one of your kidneys, please take the time to call us here at Kidney Solutions. We would love to have a talk with you about the joys of being a living donor, but we would also like to make sure that you understand everything that's involved, because it is a real undertaking. Our thoughts and prayers go out to you and to all those who are searching for a living donor. So give us a call, Kidney Solutions, 830-285-2140. I'm getting kind of excited here now because last year I had the honor, and I mean the honor, of working with Lincy Jojan, and our Jojan. I knew I was going to mess it up, Lincy. I knew I was going to. Hey,
okay.
listen, Lincy Jojan. So you got to say it fast. Okay, I worked with her we worked a long time. We're going to talk about it this morning, but I wanted to introduce her. Lincy's the lead nurse practitioner in the Department of Medicine at Northwell Health Hospital in New York. She has a bachelor's degree from St. John's College of Nursing in Bangalore, India, and a master's degree and now a doctorate from Malloy College in Rockville Center, New York. She is also, I might add, a board-certified adult nurse practitioner. Now, in my world, in my nursing world, this is a well-to-do, well-versed, and smart and articulate individual who I'm just really happy to be friends with. She's also authored a manuscript on palliative care, and it's published in the Journal of Palliative Care. And her experience as an intern with Feinstein Institutes for Medical Research has fostered her love for decision science. This is related related to acute patient care. In other words, the sick, and studying underrepresented populations. Her PhD interdisciplinary research dissertation focuses on enhancing and improving the quality of care for individuals with end-stage renal disease. So, without further ado, or me messing it up because I'm so excited, I want to welcome Dr. Lincy Jojan. How are you, Linz?
Mr. Kent? I'm pretty good, and thank you for this warm welcome and great introduction. I'm so grateful to you.
We have had some great times. You know, we spent a lot of time working to get this working for you, because I really, you know, you tickled me with your smile and your abilities, but you're most important, you're working with kidney patients. And that work with kidney patients, and especially underprivileged or underserved, it gets my heart. Yeah. And I really have gained a really close friend and protege. So give me a little family background. Tell us a little bit about yourself.
Oh, myself. Yes, Mr. Kent. So, as you know, my name is Lincy Jojan, and I came to United States approximately 19 years ago. It was the end of 2003, in the cold winter months of December. It was after Christmas. So I was just 24 years old at that time, and I was back in India. I had just completed my undergrad in nursing, bachelor's in nursing from St. John's Medical College. Is one of the reputed institution in India. And it happened that one of the hospitals, at that time, I think there was a real bad nursing shortage that was experienced across the United States at that time in 2000s, in the beginning of 2000. So one of the hospitals from New York actually came down to India, and they were looking for talented, young, energetic nurses and who had completed the proficiency exams, which was a mandate to come into United States. So I had to take a couple of qualifying exams to show that my educational qualification is equivalent to the United States education. So I had to do exams like CGFNS, TOEFL, test for spoken English, test for written English, and I excelled in those exams, and they were very excited that this young girl had completed all the exams, and I had a very good GPA, close to 4 out of 4. So, yeah. So then they hired me, and they did the processing of my visa and everything. And unfortunately, during that time, it was around 2001. And I think that's when the September 11 happened. And when the September 11, when the World Trade Center collapsed, and there was a terror attack, and as everybody knows, across the globe, everybody knows what happened at that time. So since they were processing my visa, that had to be put on hold, because at that time, the immigration processing the scrutiny was much more harder and difficult. So they said, instead of job visa, we will try to see if we can get a green card for you. So it took a while. It took close to 2 years, I would say. And I got my green card, and I arrived to United States at the end of 2003, like end of December. So I came to United States. It was a big transition from working in India and getting educated in India and coming here to US. And I had no family. I was single, and getting acclimated to everything around the hospital, the system, and the stay. And it was and I was the first generation immigrant from my family. And so it was quite an interesting start to begin with. The nursing experience was quite challenging.
I'll bet it was.
It was quite challenging, and especially when you have no support system, and then you don't have a family of your own, you don't have anybody here, and then working with diverse set of people, different personalities, and everything was challenging at that moment. And I worked there. I had a contract with that particular hospital, so I had to work for them for 3 years, but I ended up working close to 8 years, I would say, with them. And and then I met my life partner, my husband. We got married, and we had our first child by 2006. And then I told my husband that I think I need to study further. I need to pursue my education and do something more. And that's how I went for my higher studies. I went to for my master's. I did my nurse practitioner degree. And after becoming a nurse practitioner in adult health, I was offered a job at Northwell Hospital, where I'm currently working.
Right.
And yes, so I happened to start working in a new hospital, a new environment, and also it's a different job setting, from from a bedside nurse to start working as a nurse practitioner and taking independent roles and making independent decisions and becoming a practitioner. It was a totally a different arena itself, but it was much more interesting, and I wanted to take some challenging roles as well. So it's one of the largest health system in the United States, and it's a tertiary hospital. It's level 1 trauma center, and the emergency room is quite challenging, and at times it can be overwhelming too, with the pressure of the job itself. But I took every single day as an opportunity for learning, and I was mostly in the ER with seeing patients and doing admissions and so on and so forth. And as I was working as a nurse practitioner, after 4 to 5 years later, I decided I need to go further in my education, and so decided to go
Typical
for my
nurse.
PhD. It never stopped, and
It's never ending.
it was a never ending, and it was with grace of God, I got a scholarship, a federal scholarship for my PhD education. So my entire education was paid by the scholarship. So
Wow, that's great.
So I didn't have to pay a single penny for my PhD education. And so I went back for my PhD, and I always had passion for my kidney patients, because I started my journey as a young nurse back in India as a pediatric transplant nurse. So I was a transplant nurse. I was always working with pediatric population, and it was challenging. It was interesting. It was emotional, because at that time the kidneys were being donated by living donors. So usually it used to be their family members,
Sure.
either their parents or grandparents or their uncles or aunts, and the transplant was just beginning at that time. And and the hospital where I was working, that was the only hospital they were actually started the transplant program. So it was quite interesting. And, when I was young, it was very, you have all these energy, and I used to work like almost 16, 17 hours, because when you have, I was working with both the donor and the recipient, and kids especially. It was quite challenging, because they are young kids, like 2 years old, 3 years old, less than 5-year-old, and they can be irritable, and they can pull out the tubes or the thing.
Oh yeah.
And so
The
it's
little
not
critters.
easy working. Yes, it's not easy working with adults, and so I loved working with those kids and their parents, but at times when sometimes I used to feel very dejected when I saw that, some of these kids were going through rejection.
Yep.
This happens
Yeah.
like within a couple of hours, I would
Yep.
say. Post transplant, within 24 hours is very crucial after transplant. And when I started seeing these kids going through rejection, and my heart used to break. You become part of their family because you're so close to them, because you're seeing them from pre-transplant on, and then post-transplant and during the transplant and everything. And you get a sense of connection with these family members. You feel like you're part of them and they're part of you. And you start, putting yourselves in that shoes of those parents and, the family members. And that actually drifted me away from pediatric population.
Mhm.
When I
Yeah.
came to United States, I said, I don't want to be working with kids. I want to work with adults, because that put a lot of emotional turmoil in me. I felt like I just can't see them suffering. I just can't see the young kids,
I
in
get it.
pain and suffering and all that. Yeah.
It's
So
the
then
same
when I came to,
same thing that I had when I was in nursing. The worst
uh,
rotations I ever had was in pediatric because
mhm.
I had a great feeling for their it was just difficult. It
It's
wasn't
just
fun.
difficult.
Yeah, it wasn't
Yes.
fun because I go home and it's very difficult. But
Yes.
that's why we have pediatric nurses that stick with it. Thank God, praying
Hmm.
for them because
Yes.
that they have a
Yes.
passion for it, right? Just
Yes.
like we have a
They
passion now for kidney disease. Yeah.
Yes, yes. So hats off to those pediatric nurses. I worked in neonatal, I worked in with peds, and I worked for like 4 or 5 years, and then it just put so much toll on me. I felt like I was emotionally, getting
Yeah.
involved.
Yeah.
And so I needed to take a break. I thought, why don't I work with adult population and see? And while working as a nurse practitioner, especially when I started working as a nurse practitioner in my current job, and I had developed this passion for kidney from the day one as a novice nurse, and that kept growing within me. And when I started working with these adult patients, I started seeing that some of these patients who are going through kidney failures, and I was working with a couple of nephrologists, and I was seeing their interaction, the interaction between the nephrologist and the patients. And I felt that there were some who used to spend time with these patients. They were ready to listen to them, spend time with them, try to understand what their values are, what their preferences are, what their concerns are. They were able to spend time in answering their questions and concerns and include their family together in these discussions. But at times there were people, I felt them, they were so busy that they didn't have any time for these patients. And the patients used to feel like they were being neglected or they were being
Yes.
ignored. Their concerns are not being answered. And they were going through this turmoil. And this was causing a lot of anxiety within them, or a kind of panic situation where they used to tell them that you are almost at the end stage of your kidney disease and you need to decide about the treatment. And they were not given all the available alternatives, and at the same time they were forced into making a decision which was not in line with their values or in line with their preference, and they were almost forced into a decision making, and this decision was left to the provider, and the provider used to make the decision for the patient, and the patient ultimately used to feel that they were they were not satisfied with the decision being made. They were going through these conflicting thought process, whether the decision what they've done or taken up is it right, or should I have gone out and explored more, or should I have been provided with more resources, should I have been connected to a like an advocacy group like you have. where, that's something that I was so much excited when I first met you and, started looking at Kidney Solutions, your website and the podcast and the viewership that you have and the patients and the family who are connected. And that gives so much of, emotionally and psychologically and spiritually, in every manner, this gives us so much of encouragement and support for them. But that was not what I was seeing. I felt that since they were not getting any relevant information, and they were sometimes, that's when I started seeing these underrepresented population, because I started seeing some amount of bias within these providers with certain population group. And so they were not being appraised with these alternatives, and the choices were not given. There was no analytical decision making was not happening. And so the patients who had these shared decision making, as that's my topic of my dissertation itself.
Yes.
where like, what exactly is the shared decision making? So just to give a background of what shared decision making should be, and which I didn't see during my years of experience being a nurse practitioner, was patients with CKD, when they're progressing towards the end stage renal disease, they have to decide whether they have to undertake hemodialysis or peritoneal dialysis or preemptive transplantation or conservative care. Again, in hemodialysis, you have in-center hemodialysis or in-home hemodialysis. Same with peritoneal dialysis. So this is a critical component in the patient's journey. So clinicians are expected to provide patients with education and support they need to understand and integrate this complex medical information to make an informed decision based on the patient's values and preference. So this process is now referred as shared decision making. So I was looking into how this shared decision making is being implemented. And interestingly, I found that despite the decades of ethical and policy supporting shared decision making, healthcare in US has yet to become the shared decision needs to come back to the mainstream practice.
Yeah, there seems to be an extreme need to allow the patient to have options.
Yes. So that's when I felt like, there were patients who were on hemodialysis. I started seeing them, some of these patients were becoming frequent flyers. Like they come to the hospital with fluid overload, and they have missed the dialysis, and they are so upset. And so when you start having a discussion or a talk with them, and then when I started talking about shared decision making, did your provider give you decisional aid or any educational material was offered to you to in order to help you with the decision making? Where they connected you with an advocacy group? Did they connect you with a nutritionist? Did they connect you with a nurse, a dialysis nurse who could provide you with some education on the dialysis? So some of them said none of these was offered. I just crashed into dialysis. And once I was on dialysis, I felt that this was not for me. This is not what I want to do. And sometimes this was interfering in their daily lifestyle, in the sense, if somebody is a full-time worker and they were not able to take a day off. I mean, you have to go to dialysis 3 days a week and you were unable to take a day off, or sometimes some people didn't have a ride. Some people didn't wanted to manage their diet. They still wanted to eat salty foods, and they didn't want to go through any fluid restrictions. So there were a lot of things that was never being addressed with these patients. And I felt like, I started talking to these patients. They said, like, if I had a discussion about this previously, I would have straight away told them that I don't want hemodialysis. I want to be on PD. Or if they would have had a discussion done when I was in CKD stage 4 or CKD stage 3, they would have explained to me that eventually this kidney either could stabilize or it could start failing. So in that process, what would be your preferred treatment of choice? And they could have already listed them on a transplant list. And meantime, they could have started looking for a donor for
A
them.
living donor.
So,
Yeah. Yeah.
yes, so that never happened. And now I'm crashed into this dialysis, which I am not at all, happy with. I didn't wanted this, and this is not what my choice was. So I also happened to start talking with the providers, with the nephrologists, and I started asking them, why is this discussion not happening? Even though Medicare and Medicaid mandates that the provider should have a shared decision making, and decisional aid and educational material should be part of this discussion, and these are never being offered for these patients. So why is that not happening? So some of the providers started saying that, if I start having this discussion early in their course of their treatment, some of the patients don't want to listen to it. Some patients do want to listen, but they want to go for what do you say? They want to go for peritoneal dialysis, but these patients are morbidly obese, they have uncontrolled diabetes, and they have issues with mobility. So those patients cannot qualify for PD. They need to go for hemodialysis. And sometimes, again, even though Mr. Kent, you know about transplant, but to get a donor itself is sometimes harder.
Very
and
difficult.
Very, very difficult. So it's almost like you're giving life, even though you're giving life to someone, you know how important it is, but it's always people still have that thought, like they require a lot of encouragement, a lot of support. It's an inner
That's
inner,
time consuming though, isn't it?
yes,
Giving that,
yes,
stepping out of the box and saying, listen, this
yes,
person needs some extra time. But
yes,
the idea of not offering a patient all
yes,
their options right away, not waiting as
yes,
they progress through the stages, but right away.
yes,
And I've even
yes,
heard some doctors say, well, I don't want to scare the patient. Well, you're not scaring them.
yes,
You're scaring that's
exactly.
so that's what you face
That's,
there. Yeah.
yes,
And that's what
yeah,
we've gone through this many, many times with
yes,
patients. If I'd have known, I'd have
mhm,
started looking for a donor. And
yes,
so you have to, and that's what your research was about. I think,
yes,
how in the world do you get this shared decision making to be positive and get
yes,
everyone gets it, not just the
yes,
ones you think are good for this or that, but
yes.
everybody should have that option.
Mm-hmm.
And I think
So sorry.
that's where you're at with your study was the fact that
Yes,
it's not being provided. So let's prove that it's
yes,
not being. Okay.
yeah, exactly. So when I come to my dissertation, my title for on my dissertation was Chronic Kidney Disease Patients' Experience in the Decision-Making Process, the relationship between personal characteristics, where I was looking into age, sex, race, ethnicity, so on, educational status, and the stages of CKD and at what stage in CKD they were. So these were some of the personal characteristics, and decisional self-efficacy on decisional conflict and the dialysis decision in patients who participated in shared decision making. So just now I had explained what shared decision making was.
Mm-hmm.
And I had reviewed almost hundreds of literatures. And I just wanted to concise on some of the main things that I found with my review of literature. Was the key elements that I found in my literature review was it is estimated that around 700 million people around the world is affected by kidney disease. And the rate is
700
increasing.
million.
700 million.
That's a big
worldwide.
number.
It's a big, big number. Is affected by kidney disease. And the rate is increasing by 5 to 7% per year. So this number is from last year.
Yeah. And it's increasing by 5 to 7% per year?
5 to 7% per year, the number. So we have that many kidney failure patients. So
Right.
if you look at the amount of donors that we need,
Oh, it's
and
astronomical. Yeah.
it's the numbers cannot even be matched. And as we all know, there are 5 stages into CKD as it progresses. And the optimal, what I found about shared decision making, that was my another biggest concern. At what stage in CKD should there be a discussion between the provider and the patient
Excellent.
about transplantation? So
Yes, ma'am.
I found with all my literature review, the optimal timing for shared decision making should begin at stage 4 of their kidney disease. And although hemodialysis continues to be the most common mode of dialysis, it was found that hemodialysis and peritoneal dialysis had a similar outcome in the mortality and morbidity. So it doesn't matter if the patient prefers PD. I don't know why the nephrologist would prefer to go for hemodialysis. So between hemodialysis and peritoneal dialysis, it should be given to the patient.
Absolutely. There it is, that patient choice.
Yes.
Yeah.
Yes. And although kidney transplantation is the best choice, but it cannot be performed for all patients due to lack of easy access and also lack of information. So the patients still have not given enough information, like where they can find donors, or even encouraging their family members to be
A donor.
A donor itself. Yeah. And also the other thing what I noticed was when the patients put them on the list for transplantation, many of the I think Mr. Kent, you will be able to explain, like when you are in the transplant list, you have a set of things that you need to be on top of, right?
Right.
Like the echo, the lab work. And,
yep. You can't miss
right?
any of those. You
Yes,
can't,
you
you have
cannot
to
miss
do
them,
those
yes.
diligently and constantly. Yeah.
Exactly. But there are patients who have not been informed that how diligent they have to be about their own health, and to take ownership about, the blood works and the echo and everything else that need to be done, and even managing the blood sugar and, keeping up to date with their diet and exercise and everything else, which is not being encouraged and which is not being enforced, and which is and maybe there are psychological aspects to it, but
sure there
those
is.
things are not, yes. So those are not being taken. So when a kidney arrives and they make a phone call to you and say that, oh, there's a kidney available, are you ready? And this person is blinking and saying, I never followed up with my lab work, or I never did this, I never did that. So now you come to the bottom of the list again.
Right. This
somebody else gets it.
This is something we face a lot. And I say I'm a lot. I mean, I don't have numbers on it, but most of the time, when people are not doing what they're supposed to be doing, it's a lack of education and understanding. And there is a psychological point to it. But the point is then they get encapsulated into this non-compliant group, which I think is that, that's an even different part of a study that could be done. Why do people get put into that non-compliant? You know what?
Exactly.
People don't want to be sick. So why would they not want to do what they're supposed to do? And just because they don't doesn't mean they're in a place by themselves. That's where aggressive care needs to take place. And that's where shared decision making comes in handy.
Decision-making comes in handy.
Yeah, so absolutely.
Yeah, and because what I see is the shared decision making is not really happening, because as the kidney is failing, as you and me, we both know that some of these providers think that when I start talking about transplantation, when I start talking about dialysis, when I start talking about other treatment modalities, it's going to make the patient feel overwhelmed, or the patient is not going to come back to me, or he's going to find somebody else, I'm going to lose my patients, so these are the and sometimes it's like, I have no time for this, let them go and Google somewhere, or
I
now
think
the social media is so active.
I think I'm so sorry to break in on you, but you're dancing the same dance I'm dancing. It is up to the patient, but they don't. If you get 15 minutes max with a nephrologist, and that's all you get, How much
Yes.
information can you get that will be retained, number one, but number two, really instituted? Not very much.
Yes.
That's why you need
Yes.
support groups like this. That's why you need,
Yes.
that's why we do what we do, because we know
Yes.
that that little extra will get them right back into where they want to be, need to be, and they can be successful at it. But you don't get that from a 15-minute visit and here, read this on your
Mhm.
way out from a
Yes.
visit with a nephrologist. Just
Yes.
doesn't work that way.
Yes. Exactly. Yes. And so I actually was so grateful to you, Mr. Kent, that I got connected with you, because I was looking for participants for my study. So I had this interesting thought in my mind, how I can explore these kidney patients' experience. How did they go through the shared decision making, even if they had one, or did they even, if they had one or they never had one, and how was their the experience, the journey once they were diagnosed with CKD, and when they ended up with the current treatment that they're currently in. So I was so grateful for your support, your compassion, the liveliness, and the dedication that you had. As soon as I called you, there was a vibe that connected between both of us.
Yeah, you got that right.
And I was so, because I started talking to many nephrologists asking, can I, have a service sent out to your patients, because I need, this is my study, and I would like to, get their experience of their journey, and, once diagnosed with CKD, and, they were very diplomatic with that, and they just didn't want
No, they weren't going to buy
their
into
patients
that.
to be interviewed. They didn't want it to buy me. So and I was like, oh my God, how will I go through this study process? How will I get through my critical study that I am looking for, and I want to do this. So I happened to contact AAKP, the American
Yes.
Academy of Kidney
Yes.
And they told me that there is Mr. Kent, who would be the most exciting person once he hears your study. And I hope he can help you. So that's how I got connected with you. This was, I think, last year, beginning
Yes.
of last year.
A year ago, yeah.
And you gave me that support and the encouragement, and you said, you go, girl, I'm going to get those patients for you. And and you were like, you held my hand, I would say. This was a cross-country connection that we made through that phone call, and you helped me get maximum participation from your CKD patients. And I am so grateful for them, all those participants who participated in this study. And finally, I was able to reach this far, and they were so generous in sharing their stories and the experience that they had regarding the selection of their treatment choice, and what was their journey with shared decision making, whether did it really happen, or did it really didn't happen. Sorry. So interestingly, my study findings, I would just give a brief
no, go ahead. Yeah. What were your findings? Yeah.
My findings, yes. So so I was trying to test the relationship among participants' demographics, and with all the other variables that I was testing with, just as I mentioned, whether the race was influential or the sex was influential, whether the education was influential in their decision making. I found that there was a significant difference between the decision support they received from the provider and the decisional aid. So interestingly, I had 55 participants altogether in my study. And out of 55 participants, 29 participants, which accounted for 52.7%, said they were not, the decision support was not being provided by their healthcare provider. They had to make their own decision. Like they were not being, they never had any discussion with the provider. The provider didn't support them in their decision. It was left to the patient to decide whatever they want. They didn't get the support from their provider. But 26 of them felt that the provider was able to help them in finding the alternatives and giving them the pros and cons of each alternatives for them, and help the patient and the family to decide what is best for them. So as we see that almost 29 patients out of 55 had no support. There was no decision making. There was no support in their decision making, and they were left on their own to find different ways to find the choices. And coming to decision aid is it's a resource material that could be provided to the patient, and that should be. It's not like a yes or no. It should be provided to the patient in the form of educational aid, pamphlets, or educational packets, or even through online media, which can give them a lot of more help to these patients to find the alternatives and what could be the pros and cons of these alternatives. And interestingly, I found that individuals who did not receive any form of educational material were 17. 38 of them received some form of educational material, but 17 of them did not receive anything.
Oh, that's a big number for your
was
study.
A big number. Yeah, exactly. And so that was a little, disheartening. And so there was also, we found that there was a statistical significance associated with the current treatment option and the decisional conflict. So some of the patients who were on the current treatment, for example, if they were on hemodialysis or peritoneal dialysis, or even on transplant, or even on conservative care. As we know, conservative care is something that the person forgoes any form of treatment. The person wants to just focus on the quality of life instead of increasing the quantity of life. So interestingly, the study actually found that the participants who selected peritoneal dialysis as a treatment option had no decisional conflict compared to those who had chosen conservative care, hemodialysis, and even kidney transplant. So even patients who were on kidney transplant were going through some amount of decisional conflict. So that was something interesting.
That's interesting.
I feel that it could be, yes, I feel that could be related to, once they're on transplant and they go through rejection, and then now they're looking for the second kidney, or sometimes they have already got the second kidney and they're still going through rejection. So that causes a sort of decisional conflict. Should I have gone through,
Oh, that's like
again?
A survivor's thing and I'm not surviving, right?
Yes,
this is not, that was a bad decision on my part. Well, that's looking back, and we try not to do that, but you do. It's a natural thing to look back at a decision that's gone bad. All right.
Yes. And I was also trying to look, decisional self-efficacy. Decision self-efficacy is having the confidence in making the decision for yourself. So this was associated with higher level of participation in shared decision making. So that was very interesting. If you have that confidence within you that you can make the decision, ultimately, once you make the decision, you are satisfied with the decision you have made. If you don't have the confidence in you, you are like wavering in your opinions, and you don't have the confidence in making the decision. You want to leave it to somebody else to make the decision for you. Ultimately, once the decision is made and you are taken a particular treatment, and now I'm interviewing you, you are still not satisfied with the decision that you have made. You still feel, I could have taken something else instead, or so that was interesting. The other thing, what I found, that there was a negative correlation between shared decision making increase and decisional conflict. So that's almost the same thing. Like if there's a shared decision making is happening, your decision conflict is decreased. If there's a shared decision making, ultimately, once you select the treatment, your conflict is decreased. You don't have these conflicting thoughts because you have gone through the list of treatment options. You have gone through the pros and cons of treatment option. You have all your questions and concerns have been answered during the shared decision making. So now you ultimately decided to go on with X or Y treatment, and now I'm interviewing you. You don't have that decision conflict because you were well informed,
Right.
and you think you made the right choice for yourself. But if that didn't happen, then you are going through this decision conflict. Why? Or you're saying, if not this, I should have taken that, or,
Right.
you want to forego what you are currently on. So that was something interesting. And then I also found the high level of participation in shared decision making was associated with higher level of satisfaction with the decision. So just as I mentioned previously, so there is a higher. And also I found there was a significant relation between decisional self-efficacy and satisfaction with the decision. So as I mentioned, if your self-efficacy is high, your confidence level is high, so you are satisfied ultimately when you made at the end of the decision, because your confidence was high when you were making the decision, because you went through the shared decision making and you went through all the pros and cons, and you were always receptive for new information. You always were researching on your own, or your provider was giving you information as it comes along. So you were well informed of all the options, and you were not rushed into something. You were not rushed into a treatment saying that you have to do this, otherwise your kidneys are failing and you may die. So it's like a life and death situation.
Yes.
So, but you have all this time, like I mentioned previously in the review of literature itself, it tells you at the stage 4 in your CKD journey, that's the time that you need to have these discussions. It's not when you are at the end stage renal disease.
No, when they're
So
fixing to put you on dialysis, right?
Exactly. Yes. Yeah.
Yeah.
So this was an interesting study, and I am so grateful for all the participants and who gave me all the information about their experience and their life journey and their stories and how their interaction went by with their provider. Some of them were satisfied, but there were most of them who were not satisfied the way the things went on. And some of them were very diligent, like they just didn't wanted to just go by one person. They just try to research more and more.
Right.
And some felt like they were just pushed by saying, go and research on YouTube or Google. And so they were saying that was little disheartening for them, because you don't know the information that you are getting from these social media, whether it's relevant or whether they are evidence-based, or so that
Vetted.
was a little so that was very causing an anxiety in them, and they felt like they should not have been they should have been given a proper resources and proper websites and where they can get information from, instead of asking them to go look at Facebook or YouTube or Google something and get the information, and everything is out there. Those kind of response was seemed like quite unethical. And in this day and age, even though Medicare and Medicaid mandates that the provider should have a shared decision making, and it should be done using decisional aid. So, which none of them mentioned that they received a decisional aid in the decision making. So it was quite an interesting.
Well, I'm just sitting here. I'm mesmerized. I really am. The depth that you went. At some point in time, I know things can be challenged, but there's nothing in that you said that doesn't happen in real life. And we're not trying in any shape or form to try to lay all this back on, quote, the nephrologist, but we do need to lay it back on the patient. It is the obligation of the patient to reach out for this kind of thing. They need to be looking at what their options are, not just going along with the flow, right? Like they jump in the
Yes.
in the river and the river just takes them down. That's not how this works. You have to
Yes.
know everything that's going on with your body, number one.
Mhm.
But number two, what
Mhm.
are the options to fix the things that are not working? Right.
Yes.
And the sooner you
Yes.
get started on that, the sooner you realize that buying in, and then
Mhm.
you can encourage your practitioner, whoever it
Yes.
might be, to involve you in what are my options? What do I get to do?
Yes.
What should I be doing now to not only
Yes.
to slow this down, or if I'm headed
Mhm.
in some direction, what's the
Mhm.
best way to go and how quickly can I get there? There
Yes.
is a
Exactly.
right? There's a modicum of speed here, right?
Mhm. Mhm.
This is your life. This
Exactly.
is your life. This is not the doctor's life or your mom's life or
Yes.
your wife's life.
Yes.
This is your life. So you
Exactly.
have to take a firm hold of that and seek out
Mhm.
anything that you can to learn all you can about the illness.
Mhm. Yes.
And the sooner the doctor tells you you have impending kidney failure, I must tell
Mhm.
you that you have a progressive disease. We don't know how long it will take, but I
Mhm.
can tell you that's when it should start. Like you said, with at stage 4,
Mhm.
at least saying
Yes.
here are all the things that can happen that we're
Mhm.
not saying they will, but they will eventually get there. At least here are your options. And at
Yeah,
Kidney
exactly.
Solutions, we feel that transplant first is the best option. All right. But we never
Exactly.
turn
Yes.
anybody away. If you're on
Yeah,
dialysis
exactly.
now, if you're on dialysis,
Mhm.
we're going to work with you as hard to try to find a donor, but
Yes.
we're also going to try to keep you healthy enough to get transplanted.
Exactly.
So,
And that's what I feel like even the decisional aid should not be like a one size fit for all. It has to be in a manner that it can be understood by everyone at different, at different educational background, at different educational level. And it should be more simplified in a manner that they can understand the basic anatomy of kidney and how the kidney functions and how the kidney is failing and what happens when the kidney fails and what are these treatment options, how these treatments are being carried out, and what are the preparation before these treatment, and how you can remain compliant with the treatment, how and what happens if you're not compliant with these treatment, what can be the after effect or the aftermath of not being
absolutely,
compliant.
Lincy. Absolutely.
Yes. So this gives them a lot of reassurance. If this is started at stage 4, this way, they're well prepared, and the
Right.
family is well prepared too. And so that's something I felt like we can minimize the cost, the hospital cost itself. Like if somebody is non-compliant with their treatment, if you're frequently getting admitted to the hospital, the cost, the emotional
Trauma.
outbreak trauma
Yeah.
that the family is undergoing, and whoever is supporting them, and including the patient itself, so that could be minimized.
Yeah.
And so I felt
Sometimes
like this is very critical. Yes.
sometimes you get an option, right? You in life, you're given an option. And
Mm-hmm.
it's not such that, if you make a firm decision today, that it couldn't change down the line. That is the way
Exactly.
it is with all kidney disease
Mm-hmm.
patients. The only thing I can think of that is all inclusive to every patient with kidney disease is that they're
Mm-hmm.
told that they have it, number one. Number two,
Mm-hmm.
it is what it is that they have as a kidney disease. Number three, how
Mm-hmm.
progressive can it be? But all of
Yes.
those things get rolled into one thing. You have kidney disease and there's no
Mm-hmm.
cure.
Exactly.
And I mean, it's kind of like, oh, well, I don't want to scare them. Well, it's not
Mm-hmm.
scaring them. It's telling
Mm-hmm.
them that is, we can't give you the pill that takes care of kidney
Mm-hmm.
disease.
Mm-hmm.
And we can't predict as well as we would like how fast what you have in kidney disease is going to progress. But it will.
Exactly.
It will never
Mm-hmm.
go back to normal to speak of,
Exactly.
unless it's
Mm-hmm.
acute kidney. But I'm talking about most of the disease processes within chronic kidney
Mm-hmm.
disease. We can't reverse that.
Exactly. So you have to tell them the reality of
Yeah,
what you're.
right.
Yes.
So if you walk out of the office after being told you might want to look into this or we're going to follow it, what good is that? But to be told that you do have a specific illness that does is pretty much the same, but we're going to observe it very, very closely. And as it changes, we're going to change. But that's the option that should be given a patient, you know. But to be told you've got kidney disease and we're going to wait, we'll just watch for, you know.
Yes.
It's not going to work.
Exactly.
It doesn't work. Hasn't worked in 50
Exactly.
years. So why would it work now? You've done it.
True.
Listen, I think, and in my opinion, this is my opinion, that we need to go back to AAKP with this study. All right.
Oh, yeah.
I think that you and I will introduce it. I'm going to talk to some of the folks there, and I want them, and we'll disseminate and although it's not a huge study, it invites advancement. It is a study that needs to be furthered. And you kind of like struck the match. Now you're going to let it fire. And I think we should go back to AAKP and see, you told Lindsay to come to Kidney Solutions and we would help. And then this is what's happened and we need to take it farther, and they'll take it farther. Yes. Okay. So I think that's the first thing I want to do. All right. And the second thing I want to do is thank you so much for giving me a call.
Thank you. I mean, I'm so grateful. I mean, no words to express my gratitude. You've been great. You have actually helped me cross this one of a significant milestone in my academic journey. It was challenging and it was fantastic journey from the start to the end. But I couldn't have fulfilled this without your support.
You're going to get continued
participants. Without participants, I wouldn't have known their stories and their concerns. So I feel that we should always bring this up and we should take it forward. And
we're going to do that. I'm also going to invite you. I'm going to invite you to my support groups. We have been running 28, 29, 30 people every week. And we have speakers but I'd like you to come in and just talk in general about how this study has affected. And some of these people are actually in your study. Okay.
Yes.
Yeah. You may not know them and they may remember doing it, but I want to just say one thing about how important this is. When you have an individual who has had a kidney transplant, like a friend of mine for 27 years, and he can go back in time and say, you know something, I wish that the doctor would have told me that I could get transplanted.
Yes.
And that he said, in other words, not only did I want to know and wish I knew, but I wish somebody would have pounded it into my head.
I know. It's so interesting, Mr. Kent. And I thought about you yesterday. I was watching this ABC News, and this person was talking about the person who donated the kidney for this patient was the Uber driver.
Uber driver,
he said, you saw that, right? Did you see that?
I heard about it, yeah.
Yeah, it was so interesting.
Yeah.
And he said his kidneys were failing, and his doctor told him that you need to start looking for a kidney. This is what he told him, reassured him, and go find a kidney, like as if, you are going to find somewhere.
Yeah.
And
yeah.
And he was so, he said he was so emotionally down. He took this Uber, and he was sitting in this Uber car, and he told the Uber driver, what was going in his life.
Going through his head, yeah.
Yeah, and he mentioned about, like, I'm looking for kidney. And this man turns around and he said, looks like the God sent you in my car, and take my name and address and give me a call. I'm willing to donate a kidney for you.
Oh my gosh, yeah. And
Can you believe this? Can you believe this?
Yeah,
I was like,
yeah.
oh my God, I'm going to do a podcast tomorrow with Mr. Kent, and this is what I'm hearing today. I need to share this. I was like, people are, God, even though we see so much of violence and so much of hatred and so much of unrest around us and in the news, and sometimes I just don't even try to watch the news because the amount of violence and,
Mhm.
it's so painstaking. But when I just happened to turn on this and I heard about chronic kidney disease, as soon as I hear kidney disease, my antennas,
Go
spikes
right
up.
up. Yeah.
So, and I heard about this donor and how this man received his kidney, and he was so grateful. And he said, he gave me life, he gave me life.
Yeah. One fella that
So,
we had, I would never forget him, called me up and he said, you know what, Ken? He said, I think this is a good thing. Putting these flyers out around town has been good.
mhm,
And I said, yeah, it is. Well, I hope I can get some calls. And I hung up the phone after I talked with him. The minute I'd hung the phone up, I got a call.
mhm.
And this guy says, I'd like to donate my kidney. And I said, okay. And who are you interested in? And he gave me the guy's name. And I said,
Mhm.
I would love to help you get that started. Okay. And we did. And I said, by the way, where did you see that flyer?
Mhm.
And he said, oh, I saw it at Whataburger.
Wow. Can you believe this?
This
Yeah.
fellow went and put it, and one of the guys that knew him at Whataburger said, we'll put that up for you. And they slapped it up,
Mhm.
on the where you go through the pickup section, put it on
Uh-huh.
and people would write that number down and they would call. And
Oh,
so it's a matter of asking.
I know. That's
It's
what
because
there's so
God will
many
send
good
them to
people
you.
around. Exactly. There's so many, when I see that, I'm so thankful,
Yeah.
even though so much of bad things goes around, but there's so many good things
Oh
happening at
yeah.
the
And
same
that's what
time.
we should dwell on
Yes.
because the bad will always be there.
Yes.
The good will always be
Yes.
there, but it never gets credit.
Yes.
And that's,
Yes. Yeah.
yeah,
True.
yeah.
But we have to recognize those, we have to recognize those, every act of kindness that people do.
Oh,
Yeah.
these donors, let me tell you what,
Yes.
to be
I
a
know.
kidney donor or a liver donor or to leave your
Yes.
organs behind and give somebody life, there's no, unless you experience it, you can't explain it. Unless
No,
you've
it's
had this gift.
God bless them. God bless them.
Absolutely. Bless the donors.
Yes.
And there are so many out there right now, right?
Mm-hmm.
That could
Yes.
and would if they knew how. They
Yes.
could and they would
yes,
if
and
they just knew how. And that's what
right.
we do at Kidney Solutions. Just go ahead
Yes.
and give us a call. We'll tell you just exactly how you can do it.
Yeah.
All right. Our donor
God bless
coordinator.
for all the great work that you do. God
Well,
bless you.
You know what? That's a calling.
Mm-hmm.
And I'll be honest with you, I can say this, that I do it because I want to do it. I'm not obligated in any way, shape, or form, but I've been conflicted in many cases where there's no reason not to do it. I can't find a reason to quit. You know what I mean? Can't do it. And we'll continue. And all the people that are around me, Jason and Jonathan, Shannon, our donor coordinator at Kidney Solutions, all of us we have this drive, and that's to get more people transplanted, number one, but to help more people who are on dialysis, just to help them cope, give them hope. Help them hope and give them coping skills, and we do it for free.
Yes.
No charges, none. You'll never get a bill from Kidney Solutions. And all you got to do is call us. That's all you got to do. And I'm going to tell you what, you can't get rid of me, and I can't get rid of you. We're gonna walk this walk, and we're gonna make that paper of yours, that doctoral thesis. We're gonna make hay with it. We're gonna get it out there. Okay.
Yes. Thank you so much.
All right. All right.
Thank you. And that will be soon be published in ProQuest, but I'm just waiting for the editor to.
Well, as soon as it's done, as soon as it's published, we're going to preempt it. We're going to get it. We're going to get it out there. We'll get it out to all my people, all on our web.
Yes.
We're going to send it out, and
Yes.
they can share it. So it's going to go places.
Yes.
And
Yes.
and I think you believe the same thing that I do. This is just the
Mhm.
beginning for the research into this shared decision making.
Yes.
All right, just the start. We want others
Uh-huh.
to look into it, look at it, and
Yes.
embellish it, make it better.
Yes.
Right?
Yes.
That we don't want to
Yes.
just lay on the desk and I read that
Exactly.
article. I want people to
Yes.
expound on it. Do more
Mhm.
study into it. Make it more in
Mhm.
depth.
Because mhm. Because policies are in place and Medicare and Medicaid is mandating these, and they are actually getting paid for this shared decision making.
Mhm.
But these providers are not doing it.
Yep.
These providers are not taking the effort to do it. And that's what,
Should we
frustrates me,
should we give them a heads up here and tell them how really they could do it? They could just refer
Oh
to
yeah,
Kidney Solutions. That's all they have to do.
exactly.
That's all
They
they have to
have
do.
mhm.
All they have to do is refer the patient, say, hey, why
Exactly.
don't you give this guy a call or give this
Yes.
group of people a call. They'll help you.
Mhm.
And they will
They
make this
just
better, but this
mhm.
is what they'll help you with it.
Yes.
Don't rely
And
on the registered nurse in the office or the medical,
exactly.
to hand a piece of paper
Yeah,
to them, say, here, go home and read this. Instead
yes.
of handing a piece of paper, hand them a card that says, here, give these people a call. They help kidney
Yes.
patients, and it doesn't cost you a
Yes.
nickel.
Yes. And I'm trying to tell these whoever I meet, I'm trying to talk about kidney solutions in New York, in my health system, and
We
the private nephrologists that I meet.
we have tons and tons of patients. I might say tons. For me, I think we're
Mhm.
nearing 20 patients in the New York area.
Oh.
And we have patients in Texas. We have patients in
Mhm.
California. We have patients in
Mhm.
Arizona, Montana,
Mhm.
Oregon,
Mhm.
South
Mhm.
Dakota, Nebraska.
Wow.
Okay.
Uh-huh.
And all we do is get information to people. And we're
Mhm.
not donor hunters. We don't hunt for donors. We do
Yes.
work with them, but we want
Mhm.
them to see the whole continuum of kidney disease from the beginning to the end. And we'll be with
Yes.
them in that whole thing. They
Mhm.
have a mentor. All right. They will have a
Yes.
mentor from Kidney Solutions.
Mhm.
All right. We
Wonderful.
have
Wonderful.
done due diligence. And I can tell the people that are listening or who do listen to this, I'm going to ask them to share it. I guarantee
Mm.
you, if you subscribe to it and then go ahead and send it out and encourage people to listen to this podcast, number one, but let's get some shared decision making headed in the right direction. Okay.
Mhm.
This is a great podcast, and I believe that it's something that needs to get out. So when you hear it and listen to it, share it. All right. Make sure that you subscribe to it and send it out. Let people know about it, and we'll take all challengers. We have all kinds of information, so get the word out. And as soon as it's published, we will get it to you. Thank you very much for listening, and remember one thing: keep breathing.